Welcome to the Deep Dive. Today we're tackling, well, one of the toughest areas in oncology, advanced prostate cancer. It's still a major cause of death, but looking through this pile of new clinical trial data and molecular findings, it's clear things are changing fast. The standard of care isn't just evolving, it feels like it's undergoing a pretty dramatic and frankly necessary revolution.
Absolutely. And if you boil down all these sources, the core message really is molecular stratification. Success now, it seems, really hinges on matching the therapy to the specific genomic signature of the tumor. We're definitely moving away from that one-size-fits-all approach. It's precision medicine taking center stage.
And the need for this shift is stark, isn't it? I mean, we've got new drugs approved, ARPIs, taxanes, PRP inhibitors, yet the median overall survival for men with metastatic castration-resistant prostate cancer, mCRPC, it's still stubbornly less than 5 years.
Right, that 5-year mark,
Yeah.
it's a ceiling we keep hitting. And that's exactly why this research is so crucial, that we need strategies that are smarter, more targeted. We have to leverage the tumor's specific weaknesses.
Okay, let's dig into the fundamental problem first. This issue of androgen receptor, or AR, resistance. Prostate cancer feeds on hormones, so the first line is typically ADT, androgen deprivation therapy, followed by ARPIs. But eventually,
Eventually, the cancer figures it out. It adapts. There are multiple ways it does this, increasing its own hormone production, amplifying the AR gene itself, AR activating mutations, and critically, these AR splice variants emerge. They're a big problem. This cross-resistance means just switching to another existing ARPI often doesn't work for long.
so if blocking the AR protein becomes less effective because the tumor keeps finding workarounds, why not just, get rid of the protein entirely? That feels like the next logical step, leading us to AR degraders.
Exactly. That's the idea behind agents like bavdegalutamide. They basically co-opt the cell's own disposal system, the proteasome, to tag and destroy the AR protein completely. It's elimination, not just blocking.
And how's that elimination strategy working out in practice?
Well, for certain patients, those with specific AR-mutated mCRPC, bavdegalutamide showed a decent PSA50 decline, around 46%. That's promising. But, and this is a big but, it doesn't work well against those AR splice variants, the ARSVs.
Ah, so those variants,
Yeah.
they're missing the part the degrader needs to latch onto, is that it?
Pretty much. They often lack the ligand binding domain, which is what many degraders target. So yeah, the degrader can't see them effectively. It means even this approach has limitations. That's why other degraders like BMS 986365 are also important. It showed activity. About 6.3 months radiographic progression-free survival, even in heavily pretreated patients. It's definitely a space to watch.
Okay, but the research isn't just about dealing with the receptor itself. Some strategies are going way upstream, right? Trying to cut off the hormone supply at the source.
Correct. That brings us to CYP11 inhibition. Agents like opevestat target CYP11A1, which is really high up in the steroid production pathway. The goal is to shut down hormone production, starve the tumor that way. And it showed a pretty impressive 53% PSA50 response rate, particularly in patients with those ARLBD mutations.
How far upstream are we talking? Is this like stopping almost all steroid production?
Essentially, yes.
Okay.
It's very effective because it cuts off even those lower affinity steroids that might still be activating the AR, but there's a significant clinical cost. Because you're blocking system-wide hormone production, you have to give patients steroid supplements like dexamethasone to prevent adrenal insufficiency. It's quite management intensive.
Now let's talk about something potentially quite insidious mentioned in the sources, the glucocorticoid receptor, or GR, a kind of compensating mechanism.
Yeah, this is fascinating and honestly a bit worrying. The GR is closely related to the AR. When you effectively shut down the AR with ARPIs, the tumor can sometimes hijack GR signaling as a backup pathway to keep growing. And this really throws a wrench in things because corticosteroids are commonly used to manage symptoms in prostate cancer treatment.
Right, and didn't one big trial, the A for Affirm trial, show that corticosteroid use actually correlated with worse overall survival? Like we might have been inadvertently helping the tumor resist.
Precisely. It was a stark finding. It makes you really question how and when we use steroids. Unfortunately, trying to block the GR directly with drugs like relacorilant hasn't been straightforward. There have been issues with side effects or just limited effectiveness so far. It's still an ongoing challenge.
Okay, so if targeting the AR pathway directly or indirectly remains so complex, maybe the better approach is to attack the tumor based on its other fundamental weaknesses, like its inability to repair its own DNA properly.
Exactly. That pivot takes us into DNA repair defective mCRPC. And here, PRP inhibitors have become a standard of care for tumors with what's called homologous recombination repair deficiency, or HRD. Basically, these tumors are bad at fixing certain types of DNA damage.
And the key here is specificity, right? These aren't for everyone.
Absolutely not. The best results, the maximal efficacy, we see that very clearly in tumors with biallelic loss, meaning both copies are gone of BRCA2 and PALB. The big phase 3 trials, Propel, TALAPRO-2, Magnitude, all showed significant radiographic PFS benefits when PARPs were combined with ARPIs, but
Only if the patients were selected based on these biomarkers.
exactly. Biomarker selection is everything here. It's the difference between a drug working really well and not working much at all.
Okay, next target pathway, PI3KKTP10. Sounds complex, but the key seems to be PT10 loss, which is linked to a worse prognosis.
Right. This pathway often gets activated, sometimes inadvertently by AR inhibition itself, giving the tumor another way to survive. Early trials combining AKT inhibitors with abiraterone, like IP-Potential 150, were a bit underwhelming. They showed maybe a small 2-month rPFS benefit, but no overall survival advantage.
So people were maybe getting a bit discouraged about AKT inhibitors. But then something changed.
Yes, this is a great example of perseverance and refinement in clinical trials. A recent phase 3 trial looked at capivasertib, another AKT inhibitor, with abiraterone. But crucially, they focused specifically on patients with PTN-deficient metastatic hormone-sensitive prostate cancer, so earlier stage disease. And in that specific group, the trial met its primary endpoint. It improved radiographic progression-free survival.
Wow. So same class of drug, different patient population, different outcome.
Exactly. It really underscores that PTN status isn't just prognostic, it's predictive. You need to test for it and select patients accordingly. Timing and selection are critical.
And rounding out this precision section, what about the really aggressive form? Neuroendocrine prostate cancer, or NEPC, the kind that's moved beyond AR dependence.
NEPC is often linked to the loss of key tumor suppressors like TP53 and RB1. It's the tumor transforming, becoming AR independent. Strategies here often focus on the E2FE's EH2 axis, which controls cell growth. An EZH2 inhibitor, mevrometostat, combined with enzalutamide, actually showed an 8-month improvement in median rPFS in one study. That's a substantial gain for such a difficult-to-treat subtype.
Okay, so we've got new targets, new understandings of resistance, but also totally new ways of delivering the treatment to the tumor, these cellular zip code systems.
Right, targeted delivery. 2 main classes are really taking off: PSMA-targeted radioligands and antibody-drug conjugates, ADCs. Prostate-specific membrane antigen PSMA is the key target here. It's present at high levels on most prostate cancer cells, making it a good address label.
And the first type, the radioligands. Lutetium-177 is already approved and making waves, right?
Yes, lutetium-177 PSMA-617, a beta emitter, is approved for mCRPC. The PSMA-4 trial showed it improved rPFS even before chemotherapy, and the ENZAP trial, combining it with enzalutamide, showed a much longer PSA-PFS, 13 months, versus about 8 months for enzalutamide alone. Really promising combinations.
But then there's the even more potent version, the alpha emitter.
That's actinium-225 PSMA-617. Alpha particles pack a much bigger punch over a shorter distance, just 50 to 100 micrometers. They cause double-strand DNA breaks, which are very hard for cells to repair, and the results: a 57% PSA50 response rate in heavily pretreated patients. That's impressive.
Okay, impressive response. But I saw a note about side effects. Dry mouth in 95% of patients after 5 cycles. That sounds intense.
It is. It's a major issue. The salivary glands also express some PSMA, unfortunately, and they take up the actinium-225. It causes significant, often permanent, dry mouth. So while the efficacy is high, especially in late-stage disease where options are limited,
It's a serious quality of life trade-off patients and doctors have to weigh.
absolutely, it forces a very difficult discussion about balancing the potential for tumor control against a really impactful long-term side effect.
Got it. Okay, shifting to the other delivery system, ADCs, the antibody drug conjugates or smart bombs. What targets are they using besides PSMA?
They're exploring several, including STEAP1, TROP2, and B7H3. B7H3 looks particularly interesting because it's highly expressed in most mCRPC. ADCs targeting it, like one called Vobra Duo, are showing good early activity and moving quickly into phase 3 trials. And STEAP1 is another important one, which also comes up when we talk about immune therapies.
Right, let's transition there. Immunotherapy, traditional checkpoint inhibitors, ICIs, they were hugely successful in some cancers like melanoma, but initially kind of fizzled in prostate cancer. Why was that?
Yeah, prostate cancer is generally considered immunologically cold. It doesn't typically have a lot of immune cells around it or the signals needed to activate them effectively. So when ICIs like pembrolizumab were used alone, or even with chemo in unselected patients,
Right.
well, trials like Keynote 921 just didn't show an overall survival benefit. It wasn't the drug's fault, per se. The target environment wasn't right in most patients.
So again, it comes back to finding the right patients.
Exactly. Selection, selection, selection. ICIs do work, and work incredibly well in a small subset of prostate cancers, those that are hypermutated because they have mismatch repair deficiency, or DMMR. The INSPIRE trial data was striking. DMMR status was the strongest predictor of response. We're talking a median radiographic PFS of nearly 3 years, 32.7 months.
Wow. Compared to what?
Compared to maybe 4 months in unselected patients given similar therapy, it's night and day. It proves the principle: find the right molecular profile, and immunotherapy can be powerful.
But since most prostate cancers aren't DMMR, researchers needed engineered solutions, right? Like these bispecific T-cell engagers, or BSABs. Smart bridges, you call them.
Yeah, that's one way to think of it. They're engineered molecules that act like double-sided tape. One end grabs onto a T cell, usually via the CD3 receptor, and the other end grabs onto a tumor antigen, like PSMA or STEAP1 or B7H3. It physically forces the T cell right next to the cancer cell, triggering it to attack, even if the tumor environment is trying to suppress it.
And are they working?
The early data is encouraging. A STEAP1 CD3 bispecific called Xelurit-MIG, for instance, showed a 24% objective response rate and nearly 50% PSA50 response in phase 1. The main challenge, though, is managing cytokine release syndrome, or CRS. That immune activation can sometimes go into overdrive, so safety is key.
Okay, so if BSABs are the bridge, CAR T-cells are like the fully engineered soldiers, customizing a patient's own T-cells.
That's the concept. Taking a patient's T cells, genetically engineering them in the lab to express a receptor, a chimeric antigen receptor, or CAR that targets a tumor antigen like PSMA, B7H3, or STEAP1, and then infusing them back. But again, that cold tumor microenvironment in prostate cancer is a hurdle. It's often full of immunosuppressive factors like TGF-beta.
So how are they getting around that?
The innovation now is creating armored CAR T cells. For example, engineering them to resist TGF-beta signaling, like the STEAP2 CAR T mentioned in the sources. Basically, building defenses into the CAR T cells so they can survive and function within that hostile tumor environment. It's still early days, but very cutting edge.
This whole deep dive really paints a picture of a field in rapid transformation. It's all about the biomarkers now.
Absolutely, connecting all these dots. The inescapable conclusion is that comprehensive genomic profiling using tissue biopsies, liquid biopsies, advanced imaging needs to become standard practice. It has to be integrated routinely. We're heading towards combination therapies guided by multiple biomarkers simultaneously. The era of treating all MCRPC the same, it's definitively over.
It's genuinely exciting to see this progress, especially knowing the goal is to push past that 5-year survival barrier. But, as we wrap up, here's a thought that kind of contrasts with all this high-tech complexity we've just discussed. We're talking CRT cells costing hundreds of thousands, incredibly complex radioligands, sophisticated inhibitors. What if, alongside all that, one of the really effective future strategies turns out to be something much simpler, maybe even inexpensive?
It's a really important point, and actually the sources hint at this too. Alongside the multi-million-dollar research into ADCs and CAR-Ts, there's also ongoing work looking at, say, altering gut microbes. We know gut dysbiosis can impact ARPI resistance, or targeting senescent cells, these persister cells that hang around after treatment and might drive resistance.
Right. So could tackling gut health or cellular aging be as impactful as a genetically engineered T cell for some patients? Whether the answer lies in extreme complexity or elegant simplicity, the core principle seems clear. Understand the specific biology of that patient's tumor. That's the key. Definitely something to mull over.